Welcome. In this session, we begin our discussion of secondary glaucomas which have angle closure as the primary mechanism of causation of glaucoma. And secondary angle closure glaucomas are subclassified mechanistically into those associated with pupillary block and those not associated with pupillary block. And the latter are further subclassified into those with an anterior pulling mechanism and those with a posterior pushing mechanism. In secondary angle closure glaucoma associated with pupillary block, the pupil is occluded usually by the crystalline lens, vitreous or the intraocular lens. And in secondary non-pupillary block angle closure glaucomas having an anterior pulling mechanism, there is usually a membrane developing in the anterior chamber angle, the contraction of which pulls the peripheral iris forwards, occluding the anterior chamber angle. And among these we have neovascular glaucoma, irido-corneal endothelial syndrome and epithelial and fibrous ingrowths. And in secondary non-pupillary block angle closure glaucomas with a posterior pushing mechanism, the pathogenetic factor pushes the crystalline lens forwards from behind, and the crystalline lens in turn pushes the iris forwards, shallowing the entire anterior chamber and occluding the anterior chamber angles. And among the secondary angle closure glaucomas with a posterior pushing mechanism, malignant glaucoma is the classic example. So lens-induced secondary angle closure glaucomas are primarily due to pupillary block. And among them, we have Phacomorphic glaucoma and glaucoma due to ectopia lentis. And under this heading, we'll also describe pupillary block glaucoma in aphakic and pseudophakic eyes which have already undergone cataract surgery. The most common setting of a phacomorphic glaucoma is intumescence of an aging cataractous lens which pushes against the pupil, causing pupillary block. And this is important to remember. Phacomorphic glaucoma usually develops slowly but can have an acute onset. And it can be difficult to differentiate whether the angle closure glaucoma is due primarily to intumescence of the cataract or primarily because of the eye being predisposed to primary angle closure. And this differentiation may be possible by examining the fellow eye, but this differentiation is not clinically important because, as we shall see, the treatment is the same for both. Clinical features which are found in an eye with phacomorphic glaucoma is an intumescent cataract as seen here in this photograph and a shallow anterior chamber relative to the fellow eye. The iris will be anteriorly convex because of the pupillary block, and the intraocular pressure will be elevated because of closure of the anterior chamber angle. There will be corneal edema, typically microcystic epithelial corneal edema because of sudden severe elevation of intraocular pressure. Treatment of phacomorphic glaucoma is reduction of intraocular pressure as early as possible, followed by extraction of the cataract, which is the definitive treatment in this situation. Reduction of intraocular pressure can be attempted with laser peripheral iridotomy and with medications such as mannitol, beta blockers, carbonic anhydrase inhibitors and alpha-2 agonists. Prostaglandin analogs are not useful in this acute setting because of their delayed onset of action, and cholinergic agonists should not be administered because they may increase the pupillary block by constricting the pupil and may push the lens iris diaphragm forward, further shallowing the anterior chamber. During extraction of the cataract, goniosynechial lysis may be needed if peripheral anterior synechia develops in chronic angle closure. In ectopia lentis, there is displacement of the crystalline lens from its normal anatomic position due to weakness of the zonular apparatus of the crystalline lens. If the displacement occurs anteriorly, there can be a pupillary block resulting in angle closure as we see here in this photograph. These two photographs belong to an eye in a patient with microspherophakia, in which we find a typically small crystalline lens. And in this photograph we see the anterior displacement of the crystalline lens into the anterior chamber. And pupillary block can also occur with a posteriorly dislocated crystalline lens when vitreous migrates forwards and clogs the pupil. Causes of displacement of the crystalline lens most commonly is due to pseudoexfoliation and trauma. Other causes of displacement of crystalline lens includes uveitis, enlargement of the globe because of high myopia, ophthalmos or megalocornea, and congenital conditions such as Marfan syndrome, microspherophakia as shown here in these two photographs, while Marquesani syndrome, homocystinuria, Ehlers-Danlos syndrome, and sulfide oxidase deficiency. This cluster of syndromes is important to remember, and we'll be further discussing them in the section on crystalline lens and cataract. Clinical features of pupillary block due to ectopia lentis is sudden onset of pain, redness, and blurring of vision, and usually we'll find phacodonesis and iridodonesis. Phacodonesis and iridodonesis refer to tremulousness of the crystalline lens and the iris respectively, which we may be able to detect on the slit lamp by asking the patient to move his or her eyes. And with dislocation or significant displacement of the crystalline lens, we may find vitreous blocking the pupil. There will be convexity of the anterior iris because of pupillary block, and in acquired conditions in which the etiology is present in the affected eye only, the anterior chamber of the affected eye will appear to be significantly shallower than that of the fellow eye. In contrast to phacomorphic glaucoma, in which the definitive treatment is extraction of the cataract, in ectopia lentis, the initial treatment of choice is laser peripheral iridotomy. This is because surgical extraction of the crystalline lens, in these cases, particularly in those with congenital conditions, is associated with significant complications. The LPI should be done ideally in two peripheral locations which are 180 degrees apart, so that the chance of both the LPIs getting blocked by the displaced crystalline lens is minimal. And in pupillary block due to microspherophakia, cycloplegics can break the pupillary block by relaxing the ciliary muscle ring, which tightens the zonular apparatus, thus tending to flatten and pull backwards the anteriorly dislocated crystalline lens. And as with phacomorphic glaucoma, myotics should be avoided because they may increase the pupillary block by constricting the pupil and make the crystalline lens more globular by contraction of the ciliary muscle ring, thus loosening the zonules. Pupillary block can occur in aphakic and pseudophakic eyes following cataract surgery by various mechanisms. The vitreous can block the pupil in aphakic eyes as shown here in this diagram, in pseudophakic eyes with posterior capsular rupture as shown here in this diagram, and in pseudophakic eyes by a similar mechanism following YAG laser posterior capsulotomy. And in a pseudophakic eye, the intraocular lens can also block the pupil, and this can happen with an anterior chamber IOL as shown here in this diagram, particularly when a peripheral iridotomy is not done or is not patent. And in this situation, typically the iris bows forward peripheral to the anterior chamber IOL optic, and the depth of the central portion of the anterior chamber is maintained by the AC IOL. The intraocular lens can also block the pupil following an otherwise uneventful cataract surgery, when retained viscoelastic in the capsular bag pushes the intraocular lens forwards against the pupil, and this is called capsular bag distension syndrome, which can be relieved by an YAG laser posterior capsulotomy. Treatment of aphakic and pseudophakic pupillary block glaucoma includes lowering of the intraocular pressure and relieving the pupillary block with either mydriatics and cycloplegics and or a laser peripheral iridotomy, but the iridotomy may be blocked by the haptic of the intraocular lens or by peripheral vitreous. The other entity which we will be discussing in this session is irido-corneal endothelial syndrome, also called ICE syndrome, which causes secondary angle closure glaucoma by an anterior pulling mechanism. In ICE syndrome, the basic pathology lies in the corneal endothelium. This abnormal corneal endothelium behaves like an epithelium and develops the properties of proliferation and migration, as a result of which this abnormal endothelium migrates posteriorly across the anterior chamber angle over the trabecular meshwork and then onto the anterior surface of the iris. This layer over the trabecular meshwork can itself cause raised intraocular pressure with a clinically open anterior chamber angle. But more typically and importantly, the fibrous tissue associated with this abnormally migrating membrane contracts, pulling the peripheral iris forwards towards the cornea, causing peripheral anterior synechia, which leads to a clinically closed anterior chamber angle. Of note, the peripheral anterior synechia in ICE syndrome extends anterior to the Schwalbe's line because the abnormal membrane which pulls the peripheral iris forwards originates from the cornea. and this is in contrast to the other common secondary angle closure glaucoma, namely neovascular glaucoma, in which peripheral anterior synechia can extend only up to the Schwalbe's line. Because the fibrovascular membrane which leads to pass in neovascular glaucoma originates on the iris, travels anteriorly over the trabecular meshwork up to the Schwalbe's line, but cannot extend over the corneal endothelium. Cause of the disease is not known, but a viral etiology has been suggested, and familial predisposition is rarely observed in this condition. 3 clinical forms have been described, but there can be considerable overlap of clinical features between them. One study described as many as 50% of IC patients having Chandler syndrome and essential iris atrophy and Cogan-Reese syndrome contributing equally to the remaining 50% of IC patients. And the term IC also describes the initials of these 3 syndromes. And it has been seen that the pattern can change in the same eye over time from one of these entities to the other. IC syndrome is clinically unilateral, and this is very important to remember. And this characteristic actually enables us to consider the diagnosis of IC syndrome in the first place. But though the disease is clinically unilateral, the fellow eye does show subclinical signs of the disease. Onset of IC syndrome is between 20 to 50 years of age and is more common in females than in males. A patient with IC syndrome present with blurring of vision, which may be worse on waking up in the morning, and the vision then improves throughout the day, which is typical of endothelial decompensation. The intraocular pressure is usually significantly elevated in an eye with IC syndrome, and the corneal endothelium typically shows a beaten bronze or hammered silver appearance resembling guttata of Fuchs' endothelial dystrophy. And as we have discussed, peripheral anterior synechia in IC syndrome typically extends anterior to Schwalbe's line, and so they are called high pass, as seen here in this photograph. Apart from unilateral high pass and raised intraocular pressure, several other clinical features may be found in an eye with IC syndrome, and all these features are said to be caused by the abnormally migrating corneal endothelium, and these features also enables us to differentiate between the 3 clinical patterns of IC syndrome. Corneal edema predominates in Chandler syndrome, and in some patients with Chandler syndrome, the intraocular pressure may not be elevated. Iris atrophy with ectopia, iris holes, heterochromia, and ectropion UV predominates in the essential iris atrophy pattern of IC syndrome. In this photograph, we see high pass associated with both corneal edema and iris atrophy. This photograph and the next shows ectopia or displaced pupil along with high pass, and in this photograph we see ectropion UV involving the entire pupillary margin. These iris features are essentially caused by the abnormally migrating corneal endothelium growing over the iris and stretching the iris towards its direction. Correctopia or displacement of the pupil occurs in the direction of the membrane, and iris holes, as seen here in this photograph, can be either stretch holes or melting holes. Stretch holes occur due to stretching of the iris by this membrane, and so occur in the iris quadrant opposite to the direction of correctopia. And melting holes are said to be due to iris ischemia and are so not associated with the direction of correctopia. Ectropion UV is due to pulling of the posterior pigment epithelium around the pupillary margin and onto the anterior surface of the iris. And this photograph shows an eye with IC syndrome with ectropion UV all around the pupillary margin. But when ectropion UV occurs in a portion of the pupillary margin, it occurs in the direction of the abnormal membrane, and so in the direction of the correctopia. In Cogan-Reese syndrome, we find iris nodules which are tan and pedunculated in nature, as seen here in this photograph, present on the anterior iris surface. Differential diagnosis of IC syndrome is important, and glaucoma can be associated with some of these entities in its differential diagnosis, which includes entities with corneal endothelial abnormality such as posterior polymorphous dystrophy and Fuchs endothelial dystrophy, conditions with iris atrophy such as Axenfeld-Rieger syndrome, iridoschistis, and aniridia, and conditions with iris nodules such as lesion nodules of neurofibromatosis, iris melanosis, tumors such as nevi and melanomas, and inflammatory iris granulomas. Specular microscopy in patients with ICE syndrome characteristically shows light-dark reversal of the corneal endothelial cells, and this is present both in the clinically affected eye as well as the subclinically affected fellow eye, and this is virtually pathognomonic of ICE syndrome, which is important to remember. And when corneal edema in the affected eye precludes specular microscopy, this light-dark reversal feature of endothelial cells in the fellow eye enables us to make the diagnosis of ICE syndrome. On specular microscopy, normal endothelial cells are lighter than their darker borders, but in ICE syndrome, the endothelial cells are darker than their periphery, as seen in this specular microphotograph. Treatment of ICE syndrome includes treatment of the corneal edema with hypertonic saline eye drops and eye ointment, and lowering of raised intraocular pressure, either medically with aqueous suppressants and prostaglandin analogues, and myotics are not effective in lowering intraocular pressure in ICE syndrome and other secondary angle closure glaucomas, because in these conditions the myotics are not able to open the anterior chamber angle. Similarly, laser trabeculoplasty is not effective in ICE syndrome as well as other secondary angle closure glaucomas. And when medical therapy fails in ICE syndrome, which is quite common, filtering surgery is required, but failure rate with trabeculectomy is quite high due to endothelialization of the trabeculectomy fistula, which occurs due to migration of the abnormal corneal endothelium into the trabeculectomy fistula. But it has been shown that YAG laser can restore patency of a trabeculectomy fistula blocked by endothelialization. The other corneal endothelial abnormalities which can be associated with glaucoma include posterior polymorphous corneal dystrophy, in which only a small proportion of patients can develop angle closure, and Fuchs endothelial dystrophy, which has been found to be statistically associated with primary open-angle glaucoma. To recap the salient points, Phacomorphic glaucoma is a secondary angle closure glaucoma in which a swollen intumescent cataract causes pupillary block. The onset of phacomorphic glaucoma can be insidious or acute. Examination will show an intumescent cataract with shallow anterior chamber, corneal haze, and raised intraocular pressure. Treatment of phacomorphic glaucoma is control of intraocular pressure as early as possible, followed by the definitive treatment of removal of the intumescent cataract. Pupillary block can occur with a subluxated lens, either when the lens moves anteriorly or by the vitreous when the lens dislocates posteriorly. Causes of lens subluxation include pseudoexfoliation, trauma, and congenital conditions such as microspherophakia. Initial treatment of choice of pupillary block due to a subluxated lens is laser peripheral iridotomy, and extraction of the crystalline lens should be done only when LPI fails to relieve the pupillary block. Pupillary block can also occur following cataract surgery when vitreous or the intraocular implant blocks the pupil. In irido-corneal endothelial syndrome or ICE syndrome, the corneal endothelium behaves like epithelium and migrates across the anterior chamber angle and over the iris, resulting in secondary glaucoma by an anterior pulling mechanism. It is typically unilateral with onset in middle age between 20 to 50 years and occurs more frequently in females. 3 clinical forms have been described with significant clinical overlap between them. On slit lamp examination, eyes with ICE syndrome will show beaten bronze appearance of corneal endothelium, high pass extending anterior to the Schwalbe's line, and raised intraocular pressure. Corneal edema predominates in Chandler syndrome. Iris atrophy with correctopia, pseudopolychoria, and ectropion uvei predominate in essential iris atrophy, and iris nodules predominate in Cogan-Rees syndrome. Specular microscopy in ICE syndrome shows light-dark reversal of the corneal endothelial cells, which is virtually pathognomonic of the condition, and this finding is often present in the fellow eye, although the disease is clinically unilateral. Treatment of ICE syndrome includes IOP-lowering medications and filtering surgery. Trabeculectomy has a significant failure rate due to endothelialization of the trabeculectomy fistula, which however can be cleared with a YAG laser. Thank you for listening.